Well, hello everyone. Guess what? It is my daughter's 20th birthday today. Happy birthday, Gracie girl. But for you all, welcome to SADS Live number 120. Great to get to be with you. I love it. I hope you enjoy these times that we've had over these past over 3+ years together. If you don't know, if it's your first time, I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic, director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic, and its complementary Winland Smith Rice Sudden Death Genomics Laboratory. Sometime we'll have a program devoted to telling you all that we've done and are doing in our program. But as in the previous 119 episodes, I'm here on behalf of Alice Laura, our CEO of the SADS Foundation, the Sudden Arrhythmia Death Syndrome Foundation, which is devoted to you, to families with SADS conditions, a variety of genetic heart conditions that, if undiagnosed, are potentially dangerous. But when diagnosed and risk stratified and treated, success is the expected outcome. And we partner together as SADS Foundation. Our mission at Mayo Clinic and our program is to help you, the families, live and thrive despite your condition. So Alice and her team, which is an amazing team at SADS Foundation, is devoted to you. I hope you enjoyed the program 2 weeks ago. I've gotten a lot of feedback with the pilot, the Delta pilot. If you don't know that, look it up. Look up program 119. I think you'll be encouraged by it. You'll be amazed by it. It's just one of those incredible life stories. And we were 2 weeks ago in the CPR AED Awareness Week for the United States of recognize the warning signs of sudden cardiac arrest, see somebody collapse and not waking up in 10 seconds, and activating the chain of survival, 911 call, push, CPR at staying alive, fast pace, chest compression only CPR, get the AED, retrieve it, apply it. And if told to shock, hit the shock button. And 2 weeks ago, we heard, didn't we, how the two pilots in the air, 40,000 feet over the Atlantic, hadn't used an AED, weren't responsible for the AED because that's the flight attendant's role to do that. And yet they got it out of the box, hooked it on their pilot, and followed the directions and had a miraculous recovery. And I will add a correction. My wife of almost 35 years served with Northwest Airlines before Delta bought them and then retired as a Delta flight attendant. Now, she told me that after we were done 2 weeks ago, that I told our pilot Northwestern Airlines, and that was a huge mistake. How could I do that? But she was with Northwest Airlines for her career. It started before we got married. She started in February of 88. We got married in December of 88. Well, more than what you want to know, but fast forward to June 16, 2023, our baby girl Grace turned 20 today. And that ended for us 17 continuous years of raising teenagers. And we loved it. It's perspective, isn't it? Everybody would say the terrible twos. We said, no way. It's the terrific twos. They would say the terrible teens. We say, no way. It's the terrific teens. And it certainly was the terrific teens. Living and thriving is what we're about in our families. It's what we're about with the SADS Foundation. Well, that's a little preamble here. We have 35 minutes on the counter for your questions, and I love them. You men, women, kids are amazing with your questions. I see before I get to the top that some really great things coming up. We have that. Join us on Tuesday, June 20th for that patient-focused development program. Very exciting to hear your voices, those with families dealing with ARVC, one of our genetic heart conditions, for the FAA the FDA to hear your thoughts. What is life like? Are you satisfied with current therapies? What are your greatest needs? What are your desires? What treatments do you need to see develop? What side effects of current therapies do you need to see eliminated? And so we want to hear from you, and so you can pre-register. It's on the sidebar, but that's one of the first ones, if not the first one, in the history of the SADS Foundation that we are taking a leadership role in facilitating that. And so now I come to the first question. And thanks for the reminder from Erin and her team. Erin's amazing, isn't she? So Erin and the rest of our team, they're incredible. Let them know that. Donate to the mission. Top corner, www.sads.org. Top right-hand corner, red, you can't miss it, says donate now. Click on that button or get a friend to click on that button. But VM is starting the first question for us. And she's asking, she's supposed to begin an antiviral for hepatitis C. And I'm assuming whether there's any concerns about the antiviral medications in terms of the genetic heart conditions. And the quick and short answer, I don't know your situation. I'm never giving personal advice to you alone until and unless you become my patient, then things are different. But in these, I try to take your questions and give an understanding of some of the thoughts and the principles behind them. Basically, no concerns about those kind of medications. And obviously, if there's clear and present danger with respect to a illness, whether it's hepatitis C or whatever, we weigh in the balance the pros and cons of medicines. And I think where this comes up the most for our SADS families, obviously, the long QT families, right? That long hit list of medications, well maintained, curated, studied, analyzed, data reviewed by Dr. Woosley and his team, www.crediblemeds.org. But that list of medicines has caused, I think, in some ways, lots of problems and confusion because sometimes it's viewed as categorically off limits. And then it prevents us from treating really important other health issues that you might be dealing with, like attention deficit disorder. And then you see that the stimulants are on the list, and then we leave you deprived of meaningful therapy if it's necessary. And we've shown that you can treat patients with long QT syndrome who have concomitant ADD, ADHD with, yes, those medicines on the hit list and do so well. And I just saw one family, LQT2, just got her ADD therapy going, and she went from D's and F's to A honor roll. So we have to treat the whole patient. And yes, those lists of medications are really important. Yes, they need to be reviewed. And I tell my families that I don't want you ever put on a medicine on this hit list without a doctor's explicit permission, your long QT doctor's explicit permission, unless it's an emergency or you're under monitoring or there's simply no alternatives. But to view those medicines as never, I think we swung it in the wrong direction and have caused some of our long QT families to have the ADD untreated and then miserable, to have their mental health issues, depression, anxiety, untreated pharmacologically out of QT fear because the SSRIs are on the hit list, and then have a situation where we have not treated the whole patient. So we must do better, and we can do better. The medicine VM is following up on is Harvoni. And honestly, I don't know that medicine. So you stumped me already, and we're not even at the bottom of the hour. So I'd have to see in micromedics, what is its generic name before I could comment on a medicine like that. And Tracy is sharing with us that she's 18 and a half weeks pregnant. Congratulations. That is awesome. Life is amazing. Just saw a family last week just with their 8-month-old baby, and just to see mom and dad uh, incredibly blessed and pleased. Tired, but blessed and pleased. But she's 18 and a half weeks pregnant and on Nadolol. My doctors haven't given me any answers about its 100% complete safe during pregnancy and breastfeeding. Well, that's good because in reality, it's really hard to give 100% safety. I suppose I can do that with the sugar pill, as in water with a little salt mixed in. My point is 100% safety is not honestly realistic. What you need to say is it safe and is the risk benefit favor continuation of your drug, whatever that drug might be, Nadolol in the case of long QT syndrome, and what is the risk to the developing baby. Now, there are drugs of guaranteed known higher risk for teratogenic potential, damaging your in utero baby, and those are avoided. We don't use them, we stop them. But then there's drugs like Nadolol and others that have very good safety data. Yet there's a story behind beta blockers, of which Nadolol is one of them, and concerns about the beta blockers, specifically one, atenolol, which we don't like for long QT or CPVT anyway, but atenolol was a beta blocker associated with IUGR, intrauterine growth retardation, small babies. And because of that, all beta blockers kind of got a guilt by association. If you're called a beta blocker, you might do the small baby thing. And then that caused doctors to move patients from their beta blocker, have them less well treated, and then have the long QT or the CPVT rear its head in that pregnant mom. And we now have two different problems, as in two tragedies. Untreated mom who could then have disease triggered sudden cardiac arrest, resulting in her death and the death of her baby. So risk benefit needs to be analyzed always. And I've come over 23 years to realize that Nadolol, and we've published this, so have others, is Nadolol and propranolol are the two best beta blockers for long QT syndrome and CPVT. Do I fear or worry about moms with long QT syndrome or CPVT who now discover that they're pregnant, having that beta blocker in their system for their developing baby? Honestly, in my program, I have no fear of that. I've seen hardly any examples of true IUGR. Are some of the babies slightly smaller? Maybe. Has it mattered? No. So again, you have to review that with your obstetrician. They and you need to be comfortable with this. It's really important. We probably need a whole program devoted to pregnancy and postpartum issues of the mom with CPVT or long QT, or the mom who is normal, but for whom the baby may or may not have long QT or CPVT because it's coming from the dad, and how we manage that. But I have no concerns. I almost never take a mom off of their Nadolol during pregnancy. I almost never have them stop feeding. I'm not worried about a little Nadolol in the breast milk in a baby who's then negative for the family's long QT. And if they're positive for the mom's long QT or the dad's long QT, a little Nadolol in the breast milk is part of the therapy. And so I think we probably have missed the mark on this one as well. Maybe today's theme is all of the things where we've missed the mark. And I think just like we have deprived meaningful treatment of long QT patients who have concomitant ADHD and or anxiety because the drug is on the list. Here's a number two example of the things that we've missed the mark of, making moms and dads very worried, anxious, unsettled about the Nadolol and what it could do to your developing baby. The concern is just not met with reality. Julie is asking, lots of people on social media seem to want to track their QTC all the time. Is there a need for that? Probably not. Great question, Julie. Uh, some people love to track it out of curiosity, out of interest, out of being, um, I would say, have a sense of what their autonomic nervous system reading is, kind of like a CGM, chronic glucose monitoring, and what that glucose value may mean to the diabetic in adjusting his or her insulin dose or other medications. But I don't, where I use the tracking, and again, um, eventually the QTC meter will get out there for consumer use. It's available. We've created it. We've developed it. We at Mayo Clinic in partnership with AliveCore. Full disclosure, there's a relationship there. FDA approved, but the AliveCore Deep Neural Network QTC value is available on their cardiomobile device. Now, it's by prescription presently, which makes it very cumbersome, complicated to get. But it's doable and it's heading in that direction. And so when we have the QTC being more readily available to you, the patient, when would I, your long QT specialist, like to use it as a warning sign? Well, I like it in my patients who are growing babies, infants, toddlers, and I might be adjusting their dose of, say, mexilitine to make sure that they're not outgrowing the dose. And so if the QTC starts rising, then maybe I need to make a dose adjustment. Where else do I like using it? In my long QT patients who do have concomitant depression and are on SSRI like Zoloft, and I might want to monitor. Right now, we say get an ECG before you start your Paxil, your Zoloft, your Celexa, your whatever, and then let's maybe get another ECG in 2 weeks. Well, if we really had QTC monitoring the way we have chronic glucose monitoring, and when we have that, we might be tracking that differently. Say, hey, check your QTC once a week or with a dose increase, or check your QTC if you're feeling under the weather and it's been 2 days of vomiting and diarrhea, and we want to see, is your QTC reacting to that illness, maybe indicating that your potassium is low, maybe needing to go get seen. So there'll be a lot of uses, not just for long QT families, but also out there in the world of non-genetics, drug centers for who treat drug-resistant tuberculosis, for example, where almost all of those drugs have a QT signal. But what if we could non-invasively simply monitor it and then have your providers react to that information? So it's going to have increased use. Tracking it every day or whatever you're doing, that might be better for an 8th grade science project, be kind of a cool science project. But do we need to be doing that? No. Is it healthy to do that? Depends. If you find power in doing that, then it's healthy. If you find anxiety provocation in doing that, turn it off. Stop doing it because I don't really need it that badly. Thanks for the question. Mohammed, do I recommend steroid therapy to patients with inflammatory myocarditis in the setting of DSP, DSG2, ALVC? Well, okay, Mohammed. So that's your one complex question of the day. It's a good question for our families out there with who might have ARVC or ALVC. That needs to be reviewed, obviously, by a multi-specialty team, weighing in the balance of what is that myocarditis. Could that myocarditis accelerate or activate a patient's genetic desmosomal substrate? And then what are the best treatments? And if the inflammatory myocarditis specialist who I use tell me that's a good idea, then I use it. Now, I am not a immune system specialist, so difficult for me to comment exactly on the details of that. But nice try, Mohammed. Kelsey, oh, that was fun, Kelsey. She strolled down memory lane. of seeing her on the Mayo Clinic Florida campus in Jacksonville, where I saw patients for my second February. And next February 2024 will be my third time down on that campus, mentoring a genetic cardiologist for our campus there, Dr. Andrew Sang, great young genetic cardiologist, and building a presence, Mayo Clinic, Windland Smith Rice Genetic Heart Program there on that campus. So it was fun to see Kelsey there, as she shared with you. She has type 2 LQT2, had a denervation surgery, has a QTC of 475. Should haunted houses with jump scares be avoided? I've never been in one before, and I do scare easily. Well, I love the question because it really gets at how now shall we live when we're treated, and what risk exposures are acceptable? Do we know that haunted houses are potential triggering settings for long QT syndrome? Yes. All long QT syndrome? Probably no. Mostly LQT2. And that link or that trigger is most obvious or most apparent when you are undiagnosed and untreated long QT syndrome. Just like swimming is a common trigger in LQT1, but that trigger association is almost always undiagnosed and therefore untreated LQT1, for which the swimming triggered an episode for which you then got diagnosed, and so forth. So is swimming still bad, still dangerous, still off limits? Probably not. In fact, just saw yesterday a patient with LQT1. She's a competitive swimmer, and another one where she just got a scholarship for, I'm not sure if it was D2 or D1 university, swimming, and she is LQT1. So my point being, most of the things for which we've generated the genotype phenotype trigger relationship, swimming, LQT1, noises, startling, boo, LQT2, postpartum setting for women with LQT2, those links are almost always in the undiagnosed, untreated patient as how the diagnosis emerged. And so now you are treated, you're diagnosed, Kelsey, or whoever. You are under good treatment for which you and your team are pleased with your treatment configuration. Now, how shall we live? Should I do something that is known to be a potential trigger? And my answer to that is it depends. So for my athletes, and where swimming is a known LQT1 trigger, a known CPVT trigger, do I tell them you can never swim? No, I tell them, you tell me, is that swimming for you O, oxygen, or O, optional? If it's towards the optional side, why bother? Why take any risk? If it's closer to O, oxygen, of course we can do it. And we can do it confidently and competently and safely. And so I would put to a patient who says, can I go into a haunted house, and say to you, is that like, I got to do it? Is it bucket list, I got to do it territory? Or is it, yeah, I could take it or leave it? If it's in the take it or leave it, leave it. Why assume any risk? If it's in the, I really, really want to do it, I think we can probably do it. Tracy is just giving an update. She had denervation surgery at Mayo. Thank you for that. We have now had, as of yesterday, I think we at Mayo Clinic did our 400th left cardiac sympathetic denervation. Is it the first line therapy for long QT? Of course not. It's still beta blocker, Nadolol or propranolol. But it is a treatment option where right now, half of those 400 patients came to it because of bad disease, breaking through therapy. Please do something to stop that. The other half have been disease not bad, treatment bad, as in my so-called beta blocker zombies. And for them, as in the woman yesterday who I saw, she said, I would take my denervation state now after 18 months since her denervation compared to how I felt on beta blockers any day. And so everything is a risk benefit equation. Is denervation side effect free? No. Does it have its own potential sequelae? Yes. And so one has to decide with every single treatment that we tailor in as to the risk benefit profile. And we recently published our experience showing that when we look back at all of my long QT patients, we found that we have at least 20 unique, distinct treatment configurations, period. In other words, we tailor therapy, we personalize it, we try to match it to the threat of the substrate, the quality of life, desires, and goals of the patient, and get us to personalized, tailored therapy. And then Julie just followed up. Is there a reason to track their QTC all the time? I think we talked about that. No, there's not a reason for all the time. And there really shouldn't be anxiety on social media. So maybe the best solution there is turn off social media, not serving a useful purpose. A family member asks, I don't have a cause for my sudden cardiac arrest. How often should I be reevaluated to look for a cause? Love that question because we're no good. This is, I guess, number 3 where we could do better. And the post-cardiac arrest evaluation is definitely one where we could do better because often what happens, you come in with your cardiac arrest, you get the drill done, we don't find a reason, you get a defibrillator. That part's appropriate. But then what happens after that is all thinking stops. Well, you got your defibrillator. What more is there to do? And I disagree with that. And many of us experts do disagree with that. We need to continue to be a detective to see, is there a reason, is the why emerging with time? Does something come manifest in your cardiac test that might say, now it's becoming clear what the name of your condition is? And so, yes, you should be reevaluated. In our program, I think that at least in the first years after a person's sudden cardiac arrest, it should be done yearly. There should be some semblance of surveillance testing in you, the cardiac arrest survivor, and in your first degree relatives, siblings, parents, children, where we cast a net to look for potential signs and signals of a name of the sudden cardiac arrest predisposing condition. And I don't have your name who asked that question, but it was a fantastic one. Sudarshan, I think that might be your first question ever. So welcome to SADS Live. If this is new for you, your name looked new to me on the sidebar, but they're sharing that your daughter, 5 months old, congrats, has both LQT1 and LQT2. Her QTC is under 500. The LQT1 came from mom, and the LQT2 came from dad, Sudarshan. And his QTC is 460. Have you seen any similar case? I can't give an assessment about your daughter. That would require an appointment. But how often do we see children or patients with more than one distinct LQT causative mutation? The answer is about 5% of all of my patients. About 5% of all of my patients are multiples, meaning they have more than one long QT causative mutation, just like the situation described by Sudarshan, getting one from the mom, one from the dad. The child gets a double dose. That's a 25% chance, by the way, of the child getting the double dose. And where that happens is if mom has LQT1 and dad has LQT1, just unlike the example here, and the child gets the double dose, then the child has bad LQT1 often and deafness. So that's what creates the so-called Dravel and Lang-Nielsen syndrome. In LQT1 and LQT2 multiples, there's no other organs involved. It just, the possibility is to have a more severe cardiac expression. And yet, in the example provided here, she doesn't have a bad QT number. It's pretty mild. And so even when you get multiples, it doesn't mean that it has to be bad, even though in papers that we've published, we've shown that in general, patients who have multiple mutations, more than one, tend to have more expression of their long QT substrate than the 95% of long QT patients who are singles. Hope that gives us a sense of things. Karen, she has a referral for me. Well, I love those. I've been seeing just amazing families every year, every day, honestly. I think I probably have the best practice in the country. People talk about burnout, and it's a common expression in life these days, in medicine, among healthcare providers, physicians. They're burnt out, and clerical work, and this, that, and the other. Not me. I love seeing you, the SADS families out there. And how can you get burnt out when you are fulfilled and blessed by seeing amazing patients and families who are going through, many of them great journeys, some of them tragic journeys, but whatever their journey, get to come along your side. I haven't found room for burnout in that formula. So I think I have you all to thank for that. But back to Karen's potential referral, 20-year-old with a defibrillator, rather than see me in Florida. So Florida is, for me, it is February of 2024. It's a little secret. I'm hoping that I can see patients on the Florida campus the month of February and on the Arizona campus the month of March. I wonder why I'm trying to get out of Rochester in February and March. Hint, minus 10 degrees. So anyway, would love to see her down there, or him, I guess. No, her. Kayla endorses the idea of a SADS and pregnancy management program. Tracy likes it too. So I guess that's on our to-do list for one of our upcoming programs. And I'm going to do that because I love that it resonates with you. And it's kind of one of my own things of, we've got to do better. Give you a little insight there. I do not like calling most of my long QT families, moms, babies, high risk pregnancies. I think that labeling has backfired, is backfiring, and is just creating anxiety and worry. And when the vast majority of long QT, CPVT, Brugada, pregnancies, labor, delivery, postpartum go very smoothly. And I think we inadvertently are just amping up the anxiety meter for a setting that should be filled with joy and excitement and not with anxiety and fear. Christina's wondering, what's the chances of a baby being born with long QT syndrome? Well, all humans, it's a great question. All humans have about a 1 in 2,000 chance of having long QT syndrome. That's how common or rare it is. Maybe as common as 1 in 1,000. All humans, so all babies, have a 1 in 500 chance of having hypertrophic cardiomyopathy, a 1 in, say, 10,000 chance of having Brugada syndrome or ARVC. Now, in a family with already established genetic heart disease, long QT, CPVT, Brugada, ARVC, in the mom or dad, then the chances for that baby created by mom or dad is 50-50. Heads, yes. Tails, no. 50% of mom's eggs, if mom has long QT syndrome, have the long QT mutation. 50% of dad's, millions of sperm, have the long QT mutation. So the baby created by mom and dad have a 50% chance of inheriting that parent's disease causative variant. And so that it's the 50-50 rule. Muhammad's follow-up question: would I discourage LQT2 moms from breastfeeding due to its potential trigger? No way. I would not discourage it. The link between breastfeeding and being a trigger is an incredibly weak link. The evidence is incredibly weak and I think flawed. And so would I discourage breastfeeding from a mother? Never. And for long QT2 moms, never. LQT1 moms, never. So in 23 years, have I ever discouraged breastfeeding because of a concern about that breastfeeding experience could be pro-arrhythmic to the mom's long QT or CPVT? Never. So that's a myth buster, I think, that needs to be busted. Just like those out there who say that long QT people can never do chocolate. Myth bust. So let's bust these myths. And thank you for giving me that question, Muhammad. And hopefully I was pretty clear in helping to debunk that myth. And I think Renee is getting potentially the last question. Let's see how I do. Hi, Renee. Is it common for long QT to also have bradycardia? My daughter has both. The QT is type 2. Really good question. So remember, bradycardia or slow heart rate is officially defined as a resting heart rate less than 60. If it's under 60, it gets called sinus bradycardia. Does it matter if it's under 60? Doesn't matter at all. Does it matter if it's under 50? Doesn't matter at all. Under 40? Probably not. Under 30? Yeah. So there's a range of sinus bradycardia that never, ever, ever matters. And so, yes, a lot of normal people have slow heart rate bradycardia. So that same amount of long QT people get to have slow heart rate just because. Now, if you are long QT and an athlete, to where you are a highly trained, endurance trained athlete, well, then that athletic training adjusted your vagal tone to help make you have a lower, slower heart rate. Does it matter? No. And so does the mutation itself, the LQT2 mutation, make a tendency for the sinus atrial node to be slower, a little pokier? Maybe. That answer is a maybe. Stay tuned for that. But even if that answer is yes, that mutation has an impact on the heart's own pacemaker, the SA node, to have it then pace the heart naturally, slightly slower in a level under 60 beats per minute to be called bradycardia. If there is a connection, it really doesn't matter. What matters is how slow is that heart rate such that will I be able to use the number one therapy for most long QT patients, which is a beta blocker. And what does the beta blocker do in part? It slows heart rate. So if you already have a naturally slow heart rate, or even if the long QT contributes to a slower heart rate than normal, how much room do I have to add the beta blocker into the treatment program before the beta blocker drives the heart rate too slow and then creates some side effects of symptomatic bradycardia, being slow, sluggish, tired, low blood pressure because my heart rate is too slow. So hopefully that gives you a perspective on that. Yeah, and Stephanie, I'll see the last one. I jumped to the end just to see how many I missed. And Stephanie is an LQT2 mom, exclusively breastfeeding her 7-week-old. And that is awesome. Case in point. So way to finish off my myth-busting exercise on that great question from Mohammed. And that brings us, everyone, to the top of the hour, to the close of SADS Live 120. Join us in 2 weeks. We're going to have a bonus one for the month of June because we're able to get 3 Fridays, every other Fridays. We did the second the 16th, and now coming up June 30th. I don't know if I can get the pregnancy program put together by then. I'll try, but we'll see what we come up with by 2 weeks from then. And then we'll have 2 weeks in July. Mark your calendars. And I think it's the 14th and 28th or whatever we decided. Aaron will post us and keep us current on that. Well, until we're together again, I want to wish you all a wonderful weekend. And yes, it's my daughter's birthday today. Did I tell you that? She's 20, but also I'm well aware in 2 days, June 18th, Father's Day. And so for all the dads out there, happy Father's Day to you men. Yeah, I'm perhaps a little biased, but us men, we have a critical role in the lives of our sons and daughters. And so for the men out there, continue to man up, be there for your son, your daughter, your wife. And for those of you who take this role of being a dad as one of the most treasured roles that we are privileged to be granted, to those men who do it that way with that commitment, happy Father's Day. See you all in 2 weeks. Blessings, everyone.